If you really are a critical thinking nurse, then you should be able to answer this question. A 78-year-old female with a history of heart failure, chronic obstructive pulmonary disease, and type 2 diabetes mellitus is admitted to the medical surgical unit with increasing shortness of breath and generalized weakness over the past 3 days. Her home medications include furosemide 40 milligrams daily, lisinopril 10 milligrams daily, metformin 1,000 milligrams twice daily, and a salmeterol/fluticasone inhaler twice daily. On assessment, she is alert but anxious, with a respiratory rate of 28 breaths per minute and shallow, labored breathing. Her oxygen saturation is 89% on room air. She has 2+ pitting edema in her lower extremities. Her arterial blood gas and an electrocardiogram were obtained and results displayed as seen above. Based on the comprehensive clinical picture, which of the following is the most immediate and critical nursing intervention? A. Administer a prescribed PRN dose of albuterol via nebulizer. B. Administer a stat dose of intravenous sodium bicarbonate as per protocol for acidosis. C. Prepare for the administration of intravenous potassium chloride. D. Increase the patient's supplemental oxygen to 6 liters per minute via nasal cannula. The patient's history of heart failure and furosemide use puts her at high risk for hypokalemia, low potassium, due to the diuretic effect of furosemide. Her COPD and elevated PaCO2 indicate respiratory acidosis. This is a chronic issue likely exacerbated by her current condition. The shortness of breath and edema could be attributed to either a heart failure exacerbation or a COPD exacerbation, creating a diagnostic challenge. Why administering a prescribed PRN dose of albuterol via nebulizer is wrong. While the patient has COPD and is showing signs of respiratory distress, albuterol, a beta agonist, can further lower serum potassium levels, potentially worsening a life-threatening arrhythmia. Therefore, this is not the most immediate and critical intervention. Why administering a stat dose of intravenous sodium bicarbonate as per protocol for acidosis is wrong. Administering sodium bicarbonate would address the pH but not the underlying cause, and could lead to fluid volume overload in a heart failure patient. The primary treatment for respiratory acidosis is to improve ventilation. Why increasing the patient's supplemental oxygen to 6 liters per minute via nasal cannula is wrong. While the patient is hypoxic, a high concentration of oxygen in a patient with chronic CO2 retention, as evidenced by the high PaCO2, can suppress the hypoxic drive to breathe, leading to further respiratory depression and worsening hypercapnia. Oxygen should be administered cautiously and titrated to maintain a target saturation, typically 88 to 92% in this population. Why C is correct. The ECG findings of flattened T waves and the presence of U waves are classic signs of hypokalemia. Hypokalemia in a patient with underlying heart disease is a medical emergency, as it can lead to fatal cardiac arrhythmias. The combination of the diuretic use, a major cause of potassium loss, and the specific ECG changes makes addressing the low potassium level the most critical and immediate priority to prevent a catastrophic cardiac event. The nurse must anticipate the need for potassium replacement and prepare for its safe administration,